Hello, everyone. My name is Jarrod James, and in this project, I took an endeavor that myself and a few colleagues worked on back in 2021 and applied Duggan's theories of leadership to the stages that we went through in our project. Our endeavor was all about establishing a community-based crisis response team in Charlotte, North Carolina. In 2020, I witnessed the deaths of Ahmaud Arbery, Breonna Taylor, and George Floyd. Witnessing all the protests across the country, I decided to research what other groups of people go through this, where their encounters with law enforcement could end up with unintended consequences. My research led me to the lives of individuals who lived with a mental health diagnosis. For instance, there were young folks like Keith Vidal, who was 18 years old, who was living with a mental health diagnosis. When he was having a mental health crisis, his parents called police, and when officers arrived, Keith was ultimately shot and killed in his home. There's also the life of Lyndon Cameron, who was 13 years old, living with autism. In 2020, his mom called 911 to get assistance with Lyndon when he was having a mental health crisis. And when the police wound up on scene, Lyndon was shot, but thankfully he survived. Now, the state has looked for ways to not criminalize mental health. However, another unintended consequence occurred, being that even though the state did not criminalize mental health by putting individuals who lived with a mental health diagnosis in jail or prison, they inadvertently put these individuals in involuntary commitment facilities, which still led to their confinement. Between 2009 and 2018, there was a 135% increase in involuntary commitments for individuals in Mecklenburg County, where the city of Charlotte was located. Between 2014 and 2018, there was a 105% increase. Now, in organizational leadership, Duggan uses the architecture analogy, beginning with the footing, the foundation, and the framing. Our footing in this case led with a constructivist view. We found that in regards to mental health emergencies or mental health crises resulted in a 911 call, some people prefer police responses due to the safety concerns and the uncertainty of the 911 scene. Others do not want a police response due to the fear of the unintended consequences when police, who aren't necessarily trained to assist individuals living with the mental health diagnoses, interact with these individuals on scene. Next was the foundation of our endeavor. Our collected data demonstrated that there was a raise in confinement in an attempt to divert individuals living with a mental health condition from jail to healthcare. This confinement was often shown with the increase in involuntary commitment orders. Going back to what I said previously, between 2014 and 2018, there was an 105% increase in involuntary commitment orders. We hypothesized that during this time, different cities were looking at ways to not criminalize mental health by not sending people who were living with a mental health diagnosis to jail, but instead someplace else. And this someplace else usually took the form of involuntary commitment, where these people were taken and confined to mental health facilities. This led us to ask the question, is there another way to do this? Meaning, is there another way to address mental health emergencies that didn't necessarily involve the police immediately and didn't ultimately end in an involuntary commitment order? We looked at programs like Cahoots in Eugene, Oregon, and Denver Star in Denver, Colorado. Denver Star responded through the 911 system to welfare checks, intoxicated person calls, trespass and unwanted persons, and other non-criminal, non-violent emergencies. And in their first 6 months, they responded to 748 calls and reduced calls to the Denver Police Department by 2.8%. The state of North Carolina had also done something similar between 2016 and 2017 with the paramedicine pilots across the state. The problem during this time was that people who were experiencing a mental health crisis ended up in the hospital emergency room, which took up much needed emergency department beds and led to high healthcare costs. The paramedicine pilot allowed ambulances to transport individuals who were experiencing a mental health crisis to someplace other than the emergency room. The results that came about was that during these cases, 62% of people were still transported to the emergency room. 21% were able to be treated at the scene. 13% were able to be transported to an acute care facility, and 4% were transported to a psychiatric hospital. This showed us that yes, there was another way to address mental health emergencies. The next part of our journey was the framing of how we organized our work. Our work in regards to leadership took the model of more leadership than leader. The members of my team, being myself, State Representative John Autry, and Cherene Caraco, CEO of Promise Resource Network, each had different strengths. My strength was that I was able to work on teams and build effective teams with my experiences through football. John was a legislative expert, being a state representative, and Cherene had firsthand experience with the mental health care system, going through it as a patient, and then coming through the system and putting together an organization to address alternative treatment measures. We relied on connective leadership to establish and achieve our objectives. Each of us had a shared interest in seeing this work come to fruition. We each had different life experiences that brought about different thought processes of how we could create something that helped the most people. And our different experiences and personalities allowed us to alter strategies for engaging with different groups in order to resonate with the most people. From there, we took a shared leadership approach and invited more people to collaborate with us by starting the North Carolina Mental Health and IBC Advocacy Working Group. Now, this was a grassroots group that brought together lobbyists, clinical social workers, peer specialists, mental health advocates, and legislative officials to brainstorm ways that we can address mental health crises in North Carolina and tackle the involuntary commitment process within the state. We drafted recommendations and sent them out to state legislators across the state that recommended a pilot program that invested in communities reimagining public safety efforts, clarified the involuntary commitment requirements for data collection and transparency, and encouraged the state to invest in peer-run recovery models to broaden our system of alternative treatment measures for individuals living with a mental health diagnosis. Since our work began, we were able to have 3 bills introduced into the North Carolina State House of Representatives. House Bill 786, which established the pilot program investing in communicatings that wanted to reimagine public safety. House Bill 787, which had requirements for improving data collection on involuntary commitments. And House Bill 788, which established requirements to help achieve better mental health recovery results. None of our bills were turned into laws. However, earlier this month, the Senate passed the state budget, which included the pilot program that we recommended that invested in communities that were looking to reimagine public safety in regards to mental health emergencies. Earlier this month as well, the city of Charlotte launched the CARES team, which paired a clinician and paramedic to answer calls for mental health, substance abuse, and homelessness calls for service through the 911 system. Through the state budget, the city was awarded $330,000 to begin the pilot program. The architecture theory introduced by Duggan, when put into practice, created a space for my colleagues and I to bring our ideas together, organize our objectives, and begin our initiatives to see our objectives come to fruition. Connective leadership allowed us to see the same goals differently. We each had different backgrounds and didn't necessarily look at the problem the same way. This was a good thing because we were able to take each of our perspectives and put it together to create recommendations that were intended to help as broad of a range of people as possible in communities and organizations across the state. Shared leadership allowed us to maximize our influence and production based on our specialties and relationships with others. Because we were able to include lobbyists into our working group and clinical social workers and peers and advocates and legislative officials, we were able to get a broad range of how to bring our objectives to fruition in a way that would be productive and beneficial and create something tangible. Connective leadership and shared leadership also decentralized command so that progress towards our objectives wouldn't be halted by any individual person. This was beneficial because this created ownership in the work and that each of us could take pieces of the work and take it back to our own networks in order to raise support for the work that we were doing as a group.